a technique which has been taken up in India across in the last 3 years. Can I have the PowerPoint, please? Yeah, thanks. So I'll keep it short, just to show you a situation where, not today, the wonderful demonstration which happened today makes it look that our goalposts have changed and we have arrived to a location with longer urethras, but taking into consideration to achieve victory in the perineum between the thighs, looking for Victo with Victo giving a victory for post-RARP incontinence for people who are living with 1 to 5 years and longer. I think it's time for us to change rules and look at what I once heard 27 years ago when I was Professor Nitin Kekre, that male incontinence is always iatrogenic and preventable and we can do it. For a male incontinence, the dilemmas are huge. In other words, it's an overnight developed phenomenon, not like the women who progressively in their parturition and in the changes in the pelvis undergo changes in their incontinence issue, which becomes a established as incontinence. Out here, coping and adjustments are not known to men who overnight on the catheter removal on 10th and 12th day by us and our colleagues find that they have never recruited their pelvic floor ever. They did their muscle training and everything, but this was never done at that age till the episode came up. And from what was the plans to realize a good dream of removing their obstructive prostate with malignancy, everything should have been clearer and happening. Suddenly the journey starts of agony, dilemma, diapers, and a lot of disgust that they go through it. And they go back to primary surgeons, they keep changing doctors, cities, etc. So are men today living with incontinence or leaving incontinence? They are leaving incontinence because the practices have changed. But we look at driving a lot of inspiration from the work that we have been doing around and making them better minus complications. But if complications happen, as in this case of an individual who is going through a situation where I hope the videos play. Okay. I hope this video plays. Okay, so we move on for 7.5-8 minutes. So entering the perineum and keeping it as sterile as possible in a man with overnight antibiotics, a catheter 16 French in C2 and dissecting the perineum through a shorter incision, keeping the surgery as short as possible with plans towards getting the right cuff. So Victo from Promedon comes with 5 cuffs, and I'm carrying this in my pocket, and that's what a pre-connected device which actually makes wonders in the perineum is what we'll discuss in the next few minutes. So short incision. If you haven't undergone a radiotherapy, then I would like to go outside the muscle, but if not radiotherapy and not a diabetic patient, an individual who has got good blood supply, then I go all the way to the bulbospongiosus and look at the dissection of the urethra out here like we do for the urethroplasties, but quite limited enough just to be able to look at 2 things. 1, not to injure the urethra here, and number 2, dissect the urethra out to be able to place the cuff. The cuff is a measurement which we do once we have gone across. So this should take some time because I've heard injuries happening at this point and then it becomes very difficult for the surgeon to look into what next. Prosthesis with urinary leakage around. So out here, once the dissection is completed good enough, that's the sizer of the measurement. Victo comes with 5 sizes from 3.7, 4, 4.5, 5 and 5.5. So you have got enough to measure, and the 5.5 will be required more if you're going through atrophied ones where you will keep the muscle on. Out here we look at whether it's loose, snug or tight. So we choose it around 5.5, 5 and 4. This is important. This is where we spend some time looking at what could be snug and what could be too tight. You don't want a hypercontinent patient on the table on that day. So you look at measuring it again, go from the other side, look at measuring it second time. And be very careful around also to take opinions from people who are watching you from the sides on the shoulder to look at, is it 5, is it 5.5? We chose 4.5 in this patient. This is one of the workshop cases of the 12 cases we've done till now. And this looks like 4.5. So that's the Victo which I've opened up. It has got a pre-connected device of, you can see the colors, that white color is related to the urethral cuff, so no confusions on that going in a different plane. And the air removal is all that we start doing for the next few minutes. After we've done dissection, the perineum, go back to the table and look at dissection and go back again. So out here, the removal of the air part is important. The good thing about the scrotal pump is that it has got a self-sealing port which takes a coring needle of 25 French, goes through the center of it and would allow both inflation at the same time deflation. It's to be placed very much in the center. So when we do it around, we look at using our cuffs and then deflating and getting all the air out. Tiny air bubbles are acceptable, but in most cases we get the air bubble out over the next 10-15 minutes of this enterprise of pumping out from the cuff and then clamping the cuff and then pumping out from the pressure regulating balloon. And when all the air is gone, then is the time to inflate it to 13 ml. The Victo is different from what Victo Plus was. Victo Plus had got 2 PRBs, pressure regulating balloons, but Victo has stayed back as a pre-connected device and versatile enough for a starter who can actually start this doing. So once we have done the air removal, 2 syringes of 10 ml and 3 ml with normal saline, and this goes in all the way, inflates this pressure regulating balloon. This balloon will be getting into the peritoneal cavity. We'll take it next. So once we fill it up, we regulate it, and then we go back to the iliac crest on the right side. Preferably, I do it on the right side unless there's an appendix surgery done out there with scars around. Otherwise, we go to left side. So once this is ready and full, we have all the air out. The needle has come out of the sealing port at the top. We go back to the patient again and we start dissecting that part. So that's the self-sealing port with the, on my left hand, which has got a pressure pump. One pump deflates the urethral cuff for 2 to 3 minutes for the man, even if hypotonic bladder could be able to empty it very well. That's a small incision on the right iliac fossa. And once you take this incision, akin to a hernia surgery, we go down there, open the external oblique aponeurosis, go a little bit more down, and out there I'll be able to find the peritoneal lining. Once that is done, I would take a purse string suture and then deflate my balloon with my fingers and place it intraperitoneally over a purse string suture. So that's what is being done. This, like all other prosthetic surgeries that we do, is an early morning surgery before the traffic arrives or less traffic. So that's the peritoneum, holding Victo and making a small incision enough. So somebody asked me, why do we not put it anywhere else? That's the best place to stay because you have only one chance to place this, where there'll be no possibilities of fibrosis happening with layers dissected superficial to it. This just lies down there. The balloon gets deflated with our fingers and then we gently push it inside. As we press the balloon, the saline flows into other aspects of the 3-piece, and thereafter it's closure of the purse string and the abdominal part of surgery is over. Now you have a transparent tubing you can see which will go to the scrotum, and you have a white tubing. So that's the white tubing which will go to the urethral cuff. So it's white, and this is the transparent seal which goes into the scrotum pump. So it's colored such that it gets easy around. The best part of it is, so let me finish off this part. We have a camera cover which has been attached to bring about the cuff into the perineum without the cuff having any injuries. So once we reach there, we open that camera cover and then we gently attach it inside so that it doesn't get stuck anywhere. This is a dissection from the perineum to the abdominal side, and these are all 2 superficial different planes created so that the 2 tubings lie straight without, and then you bring it down, and as you bring it down you take away this. The attachment of this compared to the AMS is about the cuff being parallel. So that's a great thing about it. The cuff stays parallel to the tubing, and therefore the chance of kink is close to minimum. We not had a mechanical failure yet in the last 12 cases. Of the 4 were in workshops, and I gather the teams could actually take it forward on the continence mechanism. So that was an important part of placing it and blocking the cuff, and once that is done, the tubing goes to the right inguinal region. We make a second superficial plane right now, so the closure of the perineum, and thereafter a second closure now to the superficial scrotal pouch, which allows the patient looking at whether he is a left or a right-handed and giving a right superficial pump out there. So this patient would stay close to incontinent for next few weeks. We'll activate it around 3rd to 4th week. So now we see me going with another second layer, a superficial layer, to as superficial scrotum as possible. In one of the workshops, we had a filarial scrotum and we had no choice. We had to go in a very superficial plane. So we go and create this few times. And then the scrotal pump with the tubing goes on there. We trap it there with a forceps. That's the end of the story. We need to look at these tubings are not curved, kinked around. At the end of 3 to 4 weeks, with a 25 French coring needle, we inflate 4 ml inside this out here with antiseptic solution down at the level of the scrotum. So till 4 weeks, he is incontinent, allowing that area to heal well. We don't want a pressure cuff going on very quickly. Once the area heals around 3rd week, 4th week, or beyond, we go ahead and complete this around. So that should be the end of it. So are we living with diapers or leaving diapers? Probably we achieve victory with Victo and a dream realized for the incontinence that they had. And this is for a severe incontinence because the slings and attings still work for a mild incontinence.
Thanks.
Thank you so much for this. Thank you for taking over the box.
Any questions?
Thank you.
From the panel?
How is it different than the AMS?
Great question. So AMS is more expensive than this. This comes cheaper, number one, by few lakhs. Number two is this is a modification to what we have in AMS. This is a completely pre-connected stuff. Easy, you saw it, what I did is what I do in the last 12 cases. The good thing about it is the mechanical failures have been less, so the numbers have been lesser than those 40 years of AMS. This is straight compared to, if you look at the AMS, this is angulated. And the chances of this getting long-term can be trouble. So that's one good thing about it. Other than that, I think this is a modification on probably a newer generation from a Maruti to a Ferrari in terms of being a better one. Otherwise, I think both are same.
Professor Anand Kumar?
Yeah, Sanjay, what is the advantage of putting it intraperitoneal? Because when we do AMS, we put it extraperitoneally.
So you saw me making a small incision out there, few layers around. Where will I place it? I could place it just underneath the region out there, or I could place it in a place from where it can stay forever. So stay forever could be in a small incision, peritoneal cavity, it disappears forever there. I don't have those videos to show, I've taken CT scans out there. After 2.5, 3 years of the first placement we did 3 years ago, the patient is still the same very much. So I'm not sure what will happen to the fibrosis which will happen in the extraperitoneal space. We don't create a lot of space out there. Small dissection, small spaces around. So maybe somebody can innovate and place it around, but I have done all intraperitoneal.
Yeah.
What if the tubing is longer than you need? Won't it get kinked?
Come again?
What if the tubing is longer than you need? You just push it more into the peritoneum?
The problem there was, initially when it came in around the first generation, the tube was shorter. It was very difficult for initial surgeons who started in Europe. Now the tubes are good enough. This is standard size for a patient, anything 5'8" to 6". The tubes are longer. You can actually measure it. I didn't show you the measurement, but after I have put the balloon inside, I could actually look at stretching this and looking at where will I place this. This would not normally kink. This is very firm, but this can kink, the one with the scrotum. So I would look at lengthening it and probably keeping it back, giving it a longer tunnel. So just to make a longer tunnel for you not to have a kink. That has to be decided on the table only.
Yeah, thank you.
Just one question here. Did you have any time to, you need to sort of refill the balloon for better continence subsequently?
I can't hear you, I'm sorry.
Did you have to sort of adjust the balloon just like we do for atoms, so to get the better continence?
So yes, great question. So post these surgeries around, normally you fill 4 ml. It is an adjustable artificial urinary sphincter, AAS. In other words, you can actually put 1 ml extra and 1 ml extra. All my patients are not completely continent on 4 and 8 weeks. I make it a point that they are wearing still diapers in 8 or 12 weeks too, so we don't make them hypercontinent. But yes, on request and demand, we can instill even 0.5 ml, 1 ml, 1 ml, and 1 ml. There's so much of space that actually the cuff can still take it. Only thing that if you made the cuff too tight, if I had chosen 4 out here, then I would be lost to do something in future, because there will be a pressure erosion gradually happening internally, and I'll be not in a position to do more inflations because I will cause more erosions.
And second question is, if you have to do a cystoscopy for him, how do I deactivate the balloon for a while? Not 3 minutes.
So you can only deactivate for 3 minutes. So in other words, you keep it holding all the time. There's a rapid filling system down there, and there's a ordinary filling system. The rapid filling system can be kept pressed, and it will be kept open all the time.
So when you're doing a cystoscopy,
keep it pressed.
Someone has to hold the scrotum.
Yes, completely. If you're doing a cystoscopy. I've done a cystoscopy in 2 patients. So I kept it pressed completely and it was wide open.
We can discuss this because he's already carrying this. We can ask him.